So two really great people joining us today. Dr. Lee, perhaps you can go first. Mackenzie Lee is a surgical resident at Virginia Commonwealth University and our first American College of Surgeons Global Surgery Fellow, which is a new partnership we've created from the University of Utah and Virginia Commonwealth and the American College of Surgeons to work on this now, 5-year-long collaboration that American College of Surgeons has set up in Ethiopia. So I'll let you take it away.
Okay, sounds good. Can you guys see the PowerPoint screen? Okay, cool. So yeah, I guess just a brief introduction like Dr. Jairam gave. I'm a general surgery resident at Virginia Commonwealth University. In my second year of research, going back into PGY3 in a few months, I've had the opportunity to spend a few months in Hawassa, Ethiopia. I'm currently here right now, and I'll be here for 2 more months. So like she mentioned, there's been a collaboration between American College of Surgeons and Hawassa dating back to about 2018. There was involvement with about 12 different academic institutions in the US. They were trying to have rotations of faculty coming in every month, and there were a lot of programs, including Utah and VCU, that were involved in this Hawassa hub, is what they called it. And so one of the big projects that's come out of that is ATLS, which we just completed the first ATLS course in Ethiopia in the past 2 weeks, which I'm going to talk about today. That's just a little bit of a background and something that I've been fortunate to be a part of, but that's been planned for many years before I came here. So just kind of a refresher for people who haven't reviewed what ATLS is, or to get more of a global overview. So it was actually founded several decades ago in the 1980s. And there was an orthopedic surgeon who had a plane crash with his family and essentially received what he thought was suboptimal trauma care. And so from that developed ATLS, which was then taken on by American College of Surgeons, and since then has spread to over 80 countries. Currently, there are 17 geographical regions across the globe, and I'll show a picture on the next map of that. And one of their goals is a common language, common approach. So essentially, we all know that trauma is complicated. And in scenarios where there's a lot of high patient acuity, being able to be on the same page or the same wavelength or thinking of the same process when handling trauma patients is one of their main goals. So this was a map I found from 2018, but I think it's fairly updated, of the regions in ATLS. So you can see on the top right, region 17. So region 17 is what Hawassa has joined. So 17 is actually the Middle East, North Africa region, or the MENA region. So Egypt, Sudan, and kind of this whole area of the Middle East, as well as Nigeria. So as you can see, there's really the majority of the African continent hasn't taken up ATLS yet. And you can see that some of the other countries, so like Ghana, South Africa, Kenya, have all joined region 15, which is the European region. So I just thought this was interesting because Ethiopia has kind of tacked on to region 17, but if you look at the map, hopefully maybe the goal is that there could be a whole room for another region to be created as ATLS continues to expand. So this was a timeline that I just thought was kind of helpful for me, trying to go back and realize, when did this whole initiative start? And what are all the steps that had to go into this to make it happen? So the initial conversation began about almost 2 years ago in 2021. So Ethiopia had to submit an application to the Committee on Trauma, and they also had to identify their own ATLS champions. So national leaders in their healthcare field in their hospital who really wanted to take ownership of being this national directors for ATLS. So they identified, one of them is Dr. Emnet Tesfaye. She's on the right of this photo. She was the first intensivist to work at Hawassa. She arrived right before COVID, and she's made some incredible changes to the program. So she's now after the past 2 weeks, become the national director of ATLS in Ethiopia. But back in 2021, she was identified as a champion. And so thinking that their goal is to have her as the director, but then she had to go through several rounds of training to get there. In addition to her, they identified another general surgeon, Dr. Tedros. And so the two of them are really heading this program in the country. So both of them went to take the first ATLS provider course in Turkey in November 2021. And in December, the application was approved by the Committee on Trauma. So as some of you may know, there's been a lot of internal conflict in the northern part of Ethiopia, which has limited a lot of the movement forward in terms of these different programs that have been going on in Hawassa. So Hawassa is located south of Addis, so it's fairly distant from the conflict, but in terms of ATLS, we're working on these really large nationwide projects that's really forced the project to stall for about 6 or 7 months. So this past summer, there was the first in-person meeting with the Ministry of Health. And so the Ministry of Health has actually played a really large role in this promulgation. In 2021, they wanted to launch a 5-year plan to improve critical care, emergency and trauma care across the whole country. And so they have been crucial in helping to fund the majority of this program. They funded all of our participants who had to travel from different regions. And we can talk about that later in terms of sustainability, but I just wanted to point that out, to getting these national bodies involved right in the beginning of the planning stages, I think was really important. So in November, they were talking about how to identify participants, and it was decided that the Ministry of Health was going to select participants. So Hawassa or any of the ACS faculty didn't have a say in any of that. That was kind of another one of the decisions made at the top that I think we can talk about pros and cons of that later. And then in December, Dr. Emnet and Dr. Teddy, they went to go to Dubai for their second round of training for instructor training and director training. And they had actually had an issue several months earlier. They were planning to go to Beirut and ended up having visa issues, which are another challenge that's complicated a lot of this course. But thankfully, they were able to go to Dubai to complete those trainings. And then last month in January, there was a virtual site visit with the Region 17 coordinator. And so this is Dr. George Abisad. He's the chief of Region 17, which is the MENA region. And you can see he came down to Hawassa for this. And so getting them involved was, again, crucial to the success of this. And then you can see we identified the 16 participants with instructor potential somewhat late in the process, but they were identified then. So how were the faculty selected? So faculty came from 5 different countries. Ethiopia, of course, Egypt, Lebanon, Saudi Arabia, and the USA. So the faculty from Egypt, Lebanon, and Saudi were, again, part of the Region 17. So the director, the chair, the coordinator all came both from Beirut and from Egypt. And then our educator for the instructor course came from Saudi. Our participants were in 3 different specialties. So the main mix was general surgeons and emergency medical physicians, but we also had a few orthopedic surgeons in both of our courses. And so this is just a basic timetable of how the promulgation was rolled out. So the goal was to have 3 ATLS courses, to start with 1 provider course, then followed by an instructor course, and then a second provider course. And so the goal, I mean, there's several goals of this, but the first one was saying, how can we take new participants, people who take the provider course for the first time on Monday and Tuesday, and by the end of these 7 days, have them become certified instructors. And so that meant for several lucky participants, they had 7 days of ATLS in a row. But that, I think, was crucial to the promulgation, saying you're flying in faculty from 4 different countries, and trying to make the most of this week and a half that you have, and saying, how can we have Ethiopia become self-sustaining in terms of teaching and running their own ATLS courses. So this, I just were a few pictures of the simulation equipment. So We had several site visits, one in person and one virtual, before the course, but you can kind of get an idea of the amount of instruments and supplies that are necessary for these stations. And Hawassa, another reason they were chosen is because they have a very well stocked simulation infrastructure. And again, here, this was a chest tube station. I think we brought this chest tube mannequin over with us, but the majority of this equipment was already here. And so this was our initial course. So this was about 2 weeks ago on February 13th, on Monday. And I just want to go through the different faculty that we had through some pictures and kind of give you an idea of the different range of people that we had involved in instruction. So again, this is Dr. Emnet, who's now the Ethiopian National ATLS Director. She's an intensivist, EM physician, and then this is Dr. Tedros, who's a general surgeon, and now he's also ATLS course director. This was George Abisad, so he's the chief of Region 17, working out of American University of Beirut. This is Dr. Chris Dodgen, who came as an instructor, and he's a trauma surgeon at Medical College of Wisconsin, and probably has been one of the biggest liaisons between ACS and Hawassa in terms of making all of this happen. This is Dr. Laura Withers. She came from Maine Medical Center. She's an acute care surgeon there. And then this is Dr. Katie Iverson on the right, also an acute care surgeon from Medical College of Wisconsin. This was Dr. Ali Akazi, who is a general surgeon, general trauma surgeon, came from UC Irvine. This is myself teaching when I was going for an instructor candidate during the first course. And then we also had 2 other general surgery residents from Medical College of Wisconsin. So they were both PGY3s. This is Elle Thomas on the left, and this is Emmanuel here on the right, teaching their skills station. And then we can't forget the coordinators because they actually keep everything running. So I think this is one of, not to be forgotten, is that this is actually a crucial role in making sure that ATLS is able to happen on schedule and including all the points that it needs to. So this is Samir. He's a nurse from AUB, and he's also the coordinator for Region 17. And then this is Ephraim. So he's the director of the Simulation Center in Ethiopia. And so they were also doing a lot of learning back and forth. And Samir was really trying to teach Ephraim how to run a course and kind of all the small things that go into that. So these were our initial provider course outcomes. So 16 participants was the maximum that we had. We had to shift some spots around last minute to get 16, but we were able to fully fill the course. We had 9 general surgeons, 2 orthopedic surgeons, and 5 in emergency medicine critical care. We had 100% retention pass rate and just had 1 who needed to do a remediation on the written test, but everyone passed. 10 of these participants were designated as instructor potential. So that means not only did they pass the course, but they have an attitude and excitement towards learning. They're confident, they know their skills well, and we think that they would be important to involve in ATLS, and that they would really accept the mission of ATLS and want to kind of spread this throughout the country. So we arrived at that decision during a group conversation. So everyone talks about the candidates in these faculty meetings, and we discuss how people have scored on different skill stations or during lectures or on their written test, and overall what we think their role would be in the future of ATLS. So 10 out of 16 were instructor potential, and 9 of them were able to attend the course the next 2 days. So we had 2.5 days for the initial provider course. Then the instructor course was the next 2 days. And our maximum was 9 for that. And so we were able to fill that course. And then at the same time as we were doing the first provider course, we also had faculty who were going for certification. So myself, Elle, and Emmanuel were all going for our instructor certification. We'd already taken our instructor training class and have to be witness teaching a course before we can become fully certified. Dr. Emnet got certified as the director. So that was huge to have 100% certification for that. So our instructor course, these are 8 of the 9 who took the course. And we had a few other faculty who had to come in for the instructor course. So the setup is a little different for the instructor course. You actually have a role of an educator, which is someone who's had a master's in education, and often these 2 have surgical backgrounds as well. And so the goal for the instructor course is not necessarily teaching the information, but teaching how to teach the information, which was something that I think was very new to a lot of the participants and new to me as well when I took this course last month. But we had Dr. Hakim, he came from Cairo. He's the chair of Region 17. Dr. Ahmad, who's a pediatric surgeon at UAB, and then Dr. Nisreen Maghrabi, who works in Abdul Rahman bin Faisal University in Saudi. And so this was our instructor course outcomes. So we had 9 participants, 8 of them passed, and those 8 were instructor candidates. One of our participants, our orthopedic surgeon, actually had to leave the second day for Turkey. He had put his name in to potentially be called away. So we were fortunately able to kind of expedite his process and get him through. And so we had 8, so 9 took the course, 8 were instructor candidates, and 4 of those could go for certification during the second provider course. And so we ended up having 1 general surgeon and 3 emergency medicine physicians for that. And so these are just a few photos again of some of the faculty who had gone from participant and are now teaching the course 1 week later, which was really impressive. On the right, this is Dr. Bly. He's the head of the Department of General Surgery. He's teaching Dr. Lydia, who's the plastic surgeon here. And this is Dr. Kalkadon, and he's the dean of the medical school and also one of the emergency medicine physicians at Hawassa. And then 2 more, Dr. Antina here and Dr. Malaku on the right. So these are our 4 that went for certification during the second course. Our outcomes, so unfortunately we had a few empty spots during the second course, some geographical issues getting people in the right place at the right time. We did have a 92% pass rate, and 7 of our participants were designated as instructor potential. And all of our candidates who went for certification for instructors passed, which again was very exciting. So the big successes of this program: the emergency medicine department and general surgery departments worked very well together. I think that's not something you'll find in many hospitals. I know certainly in my hospital in the US, trauma surgery kind of takes the bulk of trauma patients, but here in Hawassa, emergency medicine is actually the group that initially handles a lot of the injuries that come in. But everyone worked really seamlessly together across departments. Participant engagement. So the Ministry of Health selected their candidates who they thought were going to be leaders in the field across 9 different states in Ethiopia, so 9 out of 11 states. And it was a great feeling to be in a classroom that everyone wants to be in the room, everyone wants to be there, everyone's engaged, everyone asks questions about the material, and they actively want to learn. And I think that was exciting for all of us, because we've all been in classrooms where people aren't really excited about the information they're learning, but everyone who was here for this first course was extremely engaged and went through a lot of really long days with us with great attitudes. So again, as I've said, from this course, we have 6 certified Ethiopian ATLS instructors, which technically you need 4 to run a course. So we will continue to try and certify more, but having 6 from 1.5 weeks is a really big accomplishment. And then 2 certified as directors as well. The simulation center preparation. So again, you saw some photos of how well stocked the simulation center was. But that's really important for skill stations when you're teaching the skills, needing to be able to run all the training sessions with the material that you would be using the equipment to simulate things. And then the faculty group. So again, I've mentioned we have faculty come from 5 different countries, various regions of the world, different backgrounds and training, and everyone got along. It was kind of a dream team. And I think that was one of the things that turned a really long 1.5 weeks into something that was really enjoyable for all of us. Some of the challenges. So I mentioned that the participants got selected fairly late on. And so part of that means that they got their course material with just a few days notice before the course started. And especially having to move some people around last minute means that some people hadn't even read the book, had access to the book before they showed up to take the course. The hospital infrastructure. So we had multiple power outages that would happen during the day, and all our presentations were on a projector. And so this was something that participants would have to kind of work around. Thankfully, the longest they would last would be about 10 or 15 minutes, but this was definitely something that would disrupt the day, especially when you're in the middle of a busy schedule. And the same with Wi-Fi. So the Wi-Fi at the hospital is very intermittent, it's not reliable. And so again, going into planning what material or access you'll need to material should happen before you even get to campus when you don't have reliable Wi-Fi. Equipment for skill stations, they were fairly well stocked, but we still managed to have a few things that weren't quite there. So we made a running list while we were there, and hopefully we'll be able to have all the right things for next time. Time management was very challenging. So on this right, I put a schedule of what our first day was for the provider course. And we were actually slotted to start this day at 10 a.m. because they wanted to have an opening ceremony and introduction. We had to nix that. And we even still went over the time for the time schedule for this day. We had challenges with our start times. So culturally in the US, we like to start things on time. If we start at 7:30, we start at 7:30. That's not how it works in Ethiopia. So we would try and start at 8 a.m. We usually wouldn't start until 9 a.m. at the earliest, no matter how early you told some people to show up. It just wouldn't work like that on the schedule. And so we also had to account for lunches. So most of the faculty go home for lunch and take about 2-hour lunches. And we were like, we can't have this happening. We have to retain everyone on campus. How can we accommodate this? And we were able to work with the local hotel and cater. But again, these are small things that I wouldn't have thought of before, but that when you're doing 12-hour days teaching ATLS, they can kind of change the game. Visas for international faculty. This was actually a really large problem and almost prevented our Egyptian and Lebanese faculty from joining us. I think this is also something that can be changed when things are scheduled with more time in advance. I think, again, this is something that we'll have to plan for in the future, is saying how long in advance do we need to inform faculty that they're coming, have them apply for visas. Thankfully, everything worked out this time, but in the future, it could be a challenge. And then participant selection. So of the 29 candidates that we had take the course, one of them was female. So that was something that none of us really understood what the Ministry of Health's criteria was for selecting participants. And again, that's political and it's over my head, but I hope in the future that we can provide some feedback in terms of who's actually getting these positions to learn, because it may have been diverse over emergency medicine surgeons and orthopedic surgeons, but there's definitely other areas for diversity. And then just so some of the last steps, budget creation. So as I mentioned before, the Ministry of Health played a really large role in funding the travel and accommodations for all of the participants who came from out of the region to join us. And while this may be part of their 5-year plan, it's not going to be an indefinite source of funding for ATLS. And so trying to construct a budget for the next few years, but also down the road, and saying of how do we make this something sustainable in terms of a cost perspective, and how much of the cost of bringing international faculty in versus being able to do it locally, and a lot of different factors like that. Future courses. So the plan now is to have another provider course within the next 2 or 3 months. And we're actually hoping to plan a course with COSEXA. So COSEXA is going to be in Addis in December. And COSEXA is a college of Southeast and Central Africa, and comprises a really large region of the continent that doesn't have ATLS. And so one thing we were thinking of is if we can introduce this to COSEXA, we can hopefully spread this in the area through the connections that they have. So I was actually with Dr. Dodgen last week in Addis. We were able to talk to some of the directors from COSEXA, and they seemed very amenable to being able to accommodate a course either before or after the actual conference in the beginning of December. I mentioned diversity of participants, and then I mentioned again a little bit about this continued promulgation and partnership with COSEXA. So yeah, I think that was hopefully like a fairly thorough overview, and thank you guys for listening, and I will answer any questions you have.
Fantastic. Great work, Mackenzie. Really great to hear about all the progress there. I have several comments and questions, but I actually wonder if Dr. Nunez would like to jump in. Dr. Nunez is one of my trauma colleagues here who has helped conduct ATLS or implement ATLS in Mongolia. And I suspect that he probably had lots of comments running through his head as he was hearing about this.
Yeah, this is really awesome, Mackenzie. It sounds like a rousing success. So hats off to you and Chris and Girma and the whole team. It's incredibly impressive that you had a 100% pass rate. I was just texting a friend who's an ER doc in Addis, and she was saying one of her residents or something, or juniors, took the course and passed it and loved it. To what do you attribute such success as in the pass rate? Because in Mongolia we struggle, and in many, at least in many LMICs, the pass rates are tend to be abysmal for many reasons. In Mongolia, it's because there's some translation issues. Sometimes there's just differences in education systems and educational styles. It sounds like in Ethiopia, maybe because the ER docs do take on a lot of the resuscitation and are very experienced in trauma. Or to what do you attribute such success?
Yeah, I think that's definitely part of it. I think everyone we taught was already a consultant. They had completed their training. And so they already had kind of like a very solid medical background, in addition to working in environments where they saw a lot of trauma. I think you mentioned language as well. So everyone in Ethiopia, their medical textbooks are in English. And so English is actually something that they're very comfortable in. I thought there might be some more challenges with that. But actually that turned out to be really not a problem, I think, for us at all. So again, I think all of us were kind of shocked in a very good way in terms of the success of the pass rate, and didn't feel like we were pushing people through who maybe were kind of on the fence, but really feeling like very, very solid with the people who passed. That's
great. As far as next steps go, obviously, financing it, as you alluded to, is going to be a big deal. Do you think there's enough buy-in to get a medical educator locally? Because that's kind of the last, once you have your instructors, the last sort of puzzle piece after a director and instructors is a medical educator. So that's someone with an education degree. And I'm sure that's kind of further down the road. Do you think there will be initially enough buy-in to have a fully self-sustained program?
Yeah. I think they actually already have a candidate for educator. It's not someone who's been in Hawassa while I've been here, but I have heard of a name floated around. I think the goal is that after we get a few more courses done under the belt, then we'll be able to kind of bring an educator in. I know we've kind of talked about who we want involved in the next future courses, just to kind of make sure the standard stays up before kind of like fully letting go. So I think the goal is to have ACS faculty probably around for the next 5-ish courses, and not a whole squadron of them, but maybe just 1 or 2. Yeah.
So Mackenzie, do you see a role for the Ethiopian Surgical Society to be involved with this?
Yeah, they actually are involved in it. I don't know exactly to what their role has been in contributing towards it. My understanding is there were actually some political issues in the past few years in terms of them being okay with supporting ATLS or not. So I think the biggest accomplishment in that sense was kind of getting them on board in the first place. I don't think they're contributing financially right now. But I think we're going to continue this partnership and hopefully kind of convert more of them.
Well, the Secretary General of the Ethiopian Surgical Society is a friend and colleague of mine, and he also has a degree in adult education, well, basically in surgical education. So although he is a urologist, he did for many years general surgery before that. So I don't know if you have interfaced at all with Andolem, but he's a good guy. And this may be an opportunity to sort of approach him obliquely and see if that might be an entrance to getting further support from the Surgical Society.
Yeah, I think as many connections as we can facilitate is the best right now, especially when you're trying to get something like this off the ground. I would say probably Dr. Dodgen might be the best person to contact with that, or if you send me his name, I can talk to Dr. Dodgen myself and kind of ask him what the thought is there, what the connection is. And I can also talk to like Dr. Emmy and Dr. Teddy, where I'm close with them. So thank you for raising that. I'm sure, again, as many people on our side to support this, that would be great.
I know him as mostly through urology connections, but I also do know that he is very much involved with the Surgical Society and in the Ethiopian way of training. You know, I think he did general surgery for about 10 years before he did urology. So, you know, I mean, it's not like they branch off as we do here in the States early.
Yeah.
Other comments or questions? I have a couple of comments. Sorry, Dr. Rockwell, go ahead.
Oh, it's just Mackenzie, thank you very much. So you mentioned there was a plastic surgeon in the course.
Yeah, she's we trained, so in Hawassa, we trained in terms of specialty wise, one colorectal surgeon and one plastic surgeon who again have general surgery training. They're also some of the colorectal surgeon is the chief medical officer of the hospital, and the plastic surgeon is his wife. And so they're some of the top people in the hospital as well. And so I think the thought behind that was just getting them certified in that and kind of doing like a top-down approach.
Good.
Couple of points. You know, we don't often think about the effect of ATLS when we're focused on thinking about how do we implement it and how do we roll it out, how do we expand it. Just so you know, there've been no studies showing any benefit of having ATLS training in high-income countries. Yours truly got to write 4 systematic reviews in Cochrane literature about it over the course of the last 15 years, which is a bit disheartening, right? Because you're like, well, in the richest countries in the world, if it's not useful, how useful could it be in poorer countries where half of the resources are not available? Like you can intubate somebody, but you don't have a ventilator. You don't have reliable power. So you don't really want to intubate somebody because you don't really want to connect them to a machine that's going to turn off, 5 times every 12 hours. And so there's some real challenges that go beyond just like teaching and learning and knowing these things, because they depend on systems that don't exist quite often. And so I just wanted to mention that this is the challenge with trying to promulgate curricula that are designed and created in high-income countries. So just something to keep in mind.
Yeah, that was definitely conversations we had about before the course, in terms of, I mean, exactly what you were saying, like we're teaching people to go through this very stepwise process where you really can't deviate from the ATLS way. But a lot of that is dependent on having the ET tube or having the pulse ox or having all these different things, and kind of saying, well, what's the benefit of still giving them, this education of what we would do in a high income country? Does that change their thought process at all? Or does this at least standardize their approach to trauma? I mean, again, it's too soon to tell. And I also realized I was looking for some articles about effectiveness of ATLS and realizing that there was really not any. So yeah.
So it's a real challenge. But that being said, educational courses, programs are not really studied. Like we have no randomized controlled trials suggesting you need to be a surgeon to do operations, right? Like we don't study educational programs for effectiveness. That's not how we evolved, right? Who says you have to finish 2nd grade to go on to 3rd grade? Like there's not any necessary study behind that. So educational research is really tricky. Grace, I'm going to give you the last chance to comment before we go on to Dr. Nunez, who's actually our second speaker, and we've kind of run into his time a little bit. So, Grace, go ahead.
Yes, thank you, everyone. Sorry, I can't turn on my camera. I just have a little bit of internet. I'm in Ghana now. And I just wanted to piggyback on what the last comment was about the low income in terms of the resources that we don't have. And also, I mean, I can speak for Ghana. Most of the traumas that happen are in like rural areas on the freeways. There's not enough hospitals around. And even if you go to casualty or emergency room, the ambulance, or if you're lucky, you get an ambulance, most of the time you won't. So somebody or a taxi has to take you. And when you get to the ambulance bay or the trauma bay, there are no beds. So we call it the no bed syndrome. So I was thinking that as part of ATLS, maybe the Stop the Bleed might be something that we can think about bringing to low-income countries like Africa, because I think Stop the Bleed might be more effective. We don't require a lot of resources. And also, again, if we're bringing these programs, it's best to bring them through the surgical college. You know, the Ghana has a Ghana College of Physicians and Surgeons, and that's the best place to bring it. Thank you.
Yeah, thank you. I think one thing to your point, I know that there were several virtual team courses that were taught in the past few years in different regions of Ethiopia. And again, it wasn't like ATLS is aimed at physicians, but can kind of go down to nurses and students. And I think the plan is to do more team courses kind of as we disseminate these different teaching programs. But I definitely agree with your point. And I think, again, in the conversations about utility of ATLS in these settings, Hawassa and many of these hospitals that our participants came from are referral hospitals, and they'll see patients who come with issue or bleeds or fractures, things that could have been temporized at a smaller setting to stabilize them when they got to Hawassa. Because again, as you mentioned, most times it's only transport that they receive. They're not actually receiving care when they're en route to a referral hospital. And so even by teaching them how to do a tourniquet or a splint, some of these basic things that can actually change the survival rates or success rates of these patients who come to these larger hospitals.
And Grace, do you mind just introducing yourself so that, because I don't know that everyone knows your background.
Oh, sorry. Dr. Grace Ayansu Dankwa. I'm a Ghanaian. I grew up in the US. I finished USC, University of Southern California. Then I went to Wisconsin for my University of Wisconsin in Madison for my medical education. I also have a master's in public health from Johns Hopkins. I'm a general surgeon. I finished 5 years of general surgery. Then I went to San Diego to do trauma, burn, and burn a little bit of burn reconstructive stuff. But I spent 2 years in San Diego with Dr. Potenza at the burn center. So, and I've moved back to Ghana now, and I live permanently in Ghana. I do come to the US almost every 2 months or 3 months. We try to introduce like a Teams course in Cape Coast Teaching Hospital in Cape Coast in Ghana, where we teach the not the full ATLS course, but the Teams approach. And Dr. Mona and I work now with Dr. Price for the Center for Global Surgery, and I'm the director here. His name is Dr. Edward Sullivan, and I'm kind of the assistant or deputy / everything. So we're trying to introduce a lot of programs. We do a lot of research in Ghana. We are also introducing a minimally invasive course in Ghana in 3 different centers. We have a lot of different aspects. We're doing a lot of quality control research and also programs as well in Ghana. Some of our research have come out, and some of them we're still working on them. But we do have sites in Ghana, and we're doing a lot of different programs. Thank you.
Thank you so much. Pleasure to have you on. So great. Well, should we go on to Dr. Nunez? We don't have a whole lot of time left, but maybe you can give us an introduction to your work, and Dr. Grace will be interested. You'll be interested in this as well, because this will be closer to home. Go ahead, Dr. Nunez.
All right. Thanks, Sudha. And Grace, very nice to meet you. And great job, Mackenzie. Let's see if I can zip through this. Here we are. Okay. So just to give you a general overview, let's see. We just won a grant from the Laerdal Foundation by assembling a team from the University of Utah and our partners in Ghana, Dr. Edward Sutherland, and then we combined with another team from University of Washington and KNUST in Ghana, Dr. Adam Jedu. To give you a general overview, though, taking a public health perspective of surgical systems, the Atlantic Commission recommended the collection of 6 indicators just to get a baseline or perform a situational analysis of a country's systems. And they're pictured here, generally broken down into preparedness, service delivery, and cost protection. So it's preparedness is 2-hour access to essential surgery, or a hospital that can do what's called the bellwether procedures, or laparotomy, C-section, and treatment of a long bone fracture. Surgical workforce density, service delivery, surgical volume per 100,000, and perioperative mortality. And then cost protection originally was impoverishing and catastrophic health expenditure. That is, if you need surgery, is it going to make you poor, or will it devastate you? Was fortunate enough to complete the indicator collections in Mongolia with colleagues there. We found some interesting information that we're hoping to further measure and intervene on. And the goal of these is to inform national surgical planning. So Mongolia is sort of slowly going through their plan for national surgical improvement. Dr. Jayaraman was recruited to be part of a writing group, to which she recruited me. It's put on by the World Federation of Societies of Anesthesiologists and sponsored by the Laerdal Foundation. I was able to attend a meeting there, which was their second meeting. At the first, they sort of better defined these indicators. And at the second, we're trying to put together a how-to manual for ministries of health and other interested parties on the best ways to go about collecting these things. And so at the end of this meeting, they announced 2 different grants for $90,000 US to implement these practices. They had about 18 applicants, and our team was fortunate enough to win. The other team is from South Africa, Dr. Bacard there and his team. Our team, like I said, from the University of Utah, you'll see we have Rachel Koch, our fellow. Andrew Davis is a PhD candidate in geography who worked with us in Mongolia. She's very facile with GIS, or geospatial mapping. Maura Doherty is helping with our Utah Indicators project. She is a PhD candidate in health economics. The Washington team is Dr. Barclay Stewart and Aldina Messick, who is a PhD candidate in implementation science. And I think we really got this grant because of the work that Dr. Stewart and Dr. Jedu has done. He's at, like I said, KNUST. And then Dr. Sutherland at Ensign. And we had really lots of buy-in from Dr. Ajiwotu with the Ministry of Health, who has a really heavy background in information science. So anyway, Dr. Jedu and Dr. Stewart have already collected surgical volume and have done a general sort of 2-hour mapping. And we're hoping to sort of expand on those moving forward. And so the first Utstein process was able to narrow down the 6 indicators to 5 and sort of better define them. The best way I can think to to break this down, what really is 5 projects in one, using a lot of different lots of different data sources, and even including a couple of site surveys that we're going to try to work out. So let's see if I can. Okay, so for geographic access, we're going to be using data from the Ministry of Health. They're going to tell us which hospitals, or actually the locations of all the hospitals. The National Health Insurance Scheme should give us a general idea of which hospitals can perform the bellwether procedures, or at least which ones are credentialed. And then we're going to use a combination of the District Health Information System. In Ghana, it's called DIMS. And that's at sort of the secondary or regional hospital level, to actually go through and see which hospitals, or basically verify which hospitals do perform these procedures. At the tertiary and referral center level, we may have to do a comprehensive site survey. There are 7 tertiary hospitals in Ghana. And Grace, you may be able to tell me, Dr. Jedu thinks that the information system called LIMS may have been in place long enough to where we can actually just collect it from there and not have to do site surveys for this purpose. Another unique thing we're doing is that we're hoping to pick one region of Ghana and look at all the primary, secondary, and tertiary hospitals and sort of validate the process I've just described, which I think will be very interesting. Let's see. So let's see, for surgical workforce, they do have a human resource management information system that we should be able to pull from. Surgical volume, we'll use the DIMS system, as well as that site survey at the tertiary level versus the data pull from LIMS. Looking at post-op mortality will be the same process. And in financial risk is kind of where things get a bit interesting. We can pull numbers from the national health accounts on what hospitals report having people pay out of pocket. That's really what we're interested in, is this out of pocket cost to patients. And then looking at national poverty levels and national income levels, we can use something called the Ghana Living Standard Survey. And then we'll be looking at comprehensive site surveys and regional site surveys to go one step further and actually ask patients themselves what they've paid out of pocket. We'll identify these patients on these site visits while they're in the hospital, and then we'll follow up with them 2 to 4 weeks later and to ask them actually what came out of pocket and for what reason. This process was sort of born out of the Utstein process because it's sort of well accepted that we probably shouldn't just take hospitals' words for it, that the more accurate pictures probably comes from a patient's side of things. So that is a 30,000-foot view of 5 projects in one. And we just met with the funders. Dr. Jedu and Dr. Sutherland are meeting with Dr. Adhibotu to see just what we can pull from the different data systems, and just what the size of the work we have cut out ahead of us over the next year. So I'm happy to take any questions or get any insights.
Sounds great. Sounds like a ton of work that needs to be done, but we're adventurous people, right?
That's right.
So it sounds phenomenal. I don't have any specific questions. Other comments, thoughts from everyone else? Dr. Grace, your hand is still up. I'm not sure if you meant to have that as a question, or if that's still from your previous question.
I think it's from my previous question, but I think it's a tall order. There's a lot of different parts to this, but I think it's a start. And as we go along, we would know how to sort of separate the components of it. The whole idea of the part of the self-pay care in terms of surgery, it's a huge problem here in Ghana. And that's a whole 5 or 6 other articles that we can get out of it.
Yeah.
which part, even the part that NHIS or the health insurance is supposed to pay, they don't really pay. And then there's the other aspect of this whole thing where the doctors actually charge patients separately from what the, for instance, if somebody needs for an appendectomy, the doctors will charge the patient money that, privately charge the patient money that is not required, that doesn't go to the hospital, no goes to the health insurance or anyone else. So there's a lot of monies going through that patients are being charged, and for that surgeries are being delayed, because if you don't have that kind of money, you probably will not get the procedure needed. So you're going to find a lot of interesting aspects of this study, and I can't wait to see what we come up with.
Yeah, absolutely. And part of this project is also kind of working on creating a sort of in some ways, a how-to guide or testing a how-to guide of collecting this kind of data across countries or across health systems. Because just because a group of folks published in the Lancet saying we should collect these indicators, doesn't mean that we can collect them, or that we can interpret them, or that we can actually intervene based on them. And it might be different from place to place. And so that's part of
I think mostly what the funders are interested in is what we can't do.
Yeah.
What roadblocks arise.
Yeah, and to try to do it in 1 year, we'll have to see how that goes. But at the least, it'll hopefully open up some interesting further opportunities. So great. Other comments, thoughts from everyone else? Okay. All right. Well, thank you for that whirlwind talk, Dr. Nunez. And I just want to say that it's so great to hear about all these great projects. And also just noticed that we have a very international team today. So Dennis is in South Africa, Laura's in Colombia, and Mackenzie's in Ethiopia, Grace is in Ghana, and we have several Mongolians visiting who I think Leaf jumped off, but Leaf has been kind of shepherding through our system here at the University of Utah. And it just shows what an incredible community we have. So just grateful for that. So thank you for joining us today. And next week, I believe Matt Price is talking about some of his work. I assume that'll be part of the work from Cambodia with Ray Price. But if there isn't anything else, we can adjourn till next week. So, great. Well, thanks for joining us today.
Great.
And see you next week if you have time.
Thank you. Bye.
Bye.
Thank you, everyone.